Good afternoon, and thank you so much for joining us today for an exciting webinar series on RECELL Spray-On Skin Cells, an innovation for limb salvage and wound closure. Today's guest is going to be Lisa Gould, who is a renowned plastic and reconstructive surgeon from the South Shore Health Department of Surgery and Center for Wound Healing. She's an outstanding clinical associate professor of the Warren Albert Medical School of Brown University and Department of Medicine in Rhode Island. Dr. Gould earned her MD and PhD in medical scholar program at the University of Illinois at Urbana-Champaign. She has been practicing plastics and reconstructive surgery with an emphasis on difficult wound problems since 1999. She's an affiliate professor in the Department of Molecular Pharmacology and Physiology at the University of South Florida and a clinical associate professor of medicine at Brown University. Dr. Gould brings her passion for research and education in wound care and her clinical practice at South Shore Hospital and South Shore Health Center for Wound Healing in Weymouth, Massachusetts, and to many national organizations that she serves, including the Wound Healing Society, the Alliance for Wound Care Stakeholders, the National Pressure Injury Advisory Panel, and the American College of Surgeons as a faculty. We're super excited to have her here today, and I also wanted to highlight that she's the most recent recipient of the 2024 Lifetime Achievement Award from the Wound Healing Society. Dr. Gould, thank you for joining us today to talk about your use of RECELL.
Thank you, Brad. I'm really honored to be able to talk about RECELL today and how it has changed my practice. I think that's critically important, especially for plastic surgeons to understand this new technology. Just as a disclosure, the cases that I'm going to be showing are my own experience treating patients with RECELL, and I am a paid consultant for Avita Medical. So if you think about lower extremity amputations, they have very high morbidity and mortality. And I don't often think of myself as a limb salvage surgeon, but many of the wounds that I treat would be considered limb salvage because if they weren't properly treated, they would result in amputations or worse because the mortality is so high from these devastating wounds. The limb salvage team is made up of many surgeons, and it's definitely a coordinated effort with vascular surgeons, plastic surgeons, general surgeons, orthopedics. But also we can't forget that there's medical specialists behind these patients. My patients wouldn't do well if they didn't have the hospitalists, their primary care doctors, endocrinologists, and in particular the nephrologists who are often referring patients to me that are very, very sick and need some good help in order to save their legs so that they can continue to be ambulatory. I consider myself a wound healer, and from the time I meet a patient, whether it's in the hospital or a consult in the wound center, my goal is to get that patient healed, get them out of pain, and get them back on with their life. I've faced with a lot of very difficult wound problems. I'm not a burn surgeon, but I take care of non-burn, non-thermal injuries primarily. But I'm also a researcher. So when there's something new and exciting, I want to obtain data that pertains to how those patients are doing and figure out a way to improve the objective metrics and really make the best better. So that's my goal, just get them healed and get them on their way. Today, we're going to look at some of my cases, and I'm going to explain how RECELL has changed my approach to what would be considered limb salvage. And I hope that you'll see why I'm less reluctant to recommend grafting, even when the wounds are large, or I don't think that a traditional split-thickness skin graft would work. So we're starting with the first case, who is a 77-year-old woman who has end-stage renal disease and is on dialysis. And she was referred to me by the nephrologist because she had developed what appeared to be warfarin necrosis. She developed necrosis on her right leg very quickly after being started on warfarin. And then she was to the astuteness of the nephrologist, quickly taken off of the warfarin and put on a different anticoagulant but the necrotic tissue remained. And you can see in the pictures on the left how big that area of necrosis was, and it was exquisitely painful. We know from Carolyn Fife's data that patients who have end-stage renal disease and are on dialysis do not heal well. The wound was never infected, but because of the severe pain, I recommended a staged procedure. It could not be debrided in the clinic. It was just too painful. So I recommended that we go to the operating room, debride the eschar off, and then I placed a dermal matrix because the wound bed had no granulation tissue, and she required a little bit more wound bed preparation before it would be ready for grafting. In several weeks, when her tissue had grown into the matrix, we returned to the operating room and applied the RECELL using a widely meshed but very thin split thickness skin graft and overspray with the cell suspension. She was completely healed in 11 weeks total with no need for dressings. I think the remarkable thing about this case is this is a dark-skinned patient, and her graft is dark. It will lighten up a little bit and match the rest of her leg, but it regained the pigment. And even more important, her donor site, which is very thin, quickly regained the pigment and was healed very quickly. And she was out of pain. She was finally smiling, and that's the most important thing when I'm treating a patient like her. So whether she got repigmentation in her graft or her donor site was not particularly important for this patient, but I think it's valuable for plastic surgeons to know that the cell suspension contains melanocytes that can repigment the graft site, and that the donor sites are cosmetically favorable as well. The most important part, and you'll hear me emphasize this over and over, is the wound bed preparation. It is a major reason for graft failure. Trying to graft on something that isn't ready leads to disappointment for the surgeon and for the patient. So my approach is to excise early, reducing the risk of infection. Often my general surgeons are doing that before I get to see the patient, and then they're having me help out with the rest of it. But it's important to remove all the necrotic tissue and the debris and achieve a clean but also bleeding wound bed. It needs to have a well-vascularized bed. So I'm often using a supplement or an adjunct technology, whether it be a dermal substitute or negative pressure wound therapy, and sometimes even additional serial debridements in order to get a good, clean, healthy bed that you know that the graft will take. You can't graft over fascia. You can't graft on bone. The wound bed has to be vascularized. And you often have to explain to the patient why it's taking so long, that we're not going to graft on day one, because we need to have it ready or the graft simply won't take. And plastic surgeons were all familiar with the reconstructive ladder, and skin grafting being more complex than primary or secondary closure, but certainly not as complex as free flaps. And in the medically complex patient, which is the patients I'm usually treating, getting a wound healed on an extremity usually means some sort of graft rather than a flap. And the RECELL process is another arrow in the skin grafting quiver, or a tool in a toolbox. It's just one more adjunct that we can use that creates an autologous skin cell suspension that can be used as an adjunct to grafts in full thickness injury or by itself in some partial thickness injuries. You can see the difference between the full thickness grafts and the split thickness skin grafts. Most of the time I'm looking at split thickness skin grafts in order to cover these big wounds. And then with RECELL Spray-On cells, we're using a mixture of cells with fibroblasts, keratinocytes, and melanocytes. It's pretty much at the epidermal-dermal junction because it's a very, very thin graft. And creating a cell suspension. I say it's a single cell suspension, but I can't see the cells. So we know it's a cell suspension to be sprayed on. RECELL has proven clinical safety and effectiveness with RCTs. It's really got a lot of data, starting first with partial thickness burns and an RCT comparing a 2-to-1 skin graft versus RECELL. Mixed depth burns, again, a comparison of skin graft versus RECELL, and more recently, full thickness skin defects that were non-thermal, comparing skin grafts to RECELL with widely meshed skin grafts. And now, even using RECELL on vitiligo because of the repigmentation process, which is a very interesting thing to think about and really important for plastic surgeons to understand that we can get repigmentation in grafts, including vitiligo. The ability to provide skin graft coverage with minimal donor site morbidity really opens up new possibilities for the patients. And to be honest, most patients are just completely freaked out about having a wound. But on the other hand, they may be more freaked out about the donor site because they've heard through the grapevine how awful a donor site can be. So this process was developed by Fiona Wood and Marie Stoner, who was a scientist that worked with Fiona. Fiona's a burn surgeon and plastic surgeon in Australia because of a clinical problem of really big wounds that needed to be covered. And it utilizes the regenerative capacity of the epidermis. It is point of care, preparing in the operating room, and with an up to 1 to 80 donor site expansion. And we're going to talk about the actual process and show a little bit about the device and the process itself. The RECELL Go system is a next-gen system, but the preparation is the same. So harvesting the skin graft at a very thin level at 0.006 to 0.008. We're, as plastic surgeons, most of us are used to going 0.012 to 0.015. And so that's a big difference, being able to harvest the skin at that thin level. And that's why it heals so fast. And then the skin is meshed. I use 3-to-1. Some people have 4-to-1 meshers. I only have a 3-to-1. And then a segment of it is put into the RECELL Go for processing into the autologous spray-on skin cells. As I said, this is the next generation way to process the skin cells. And this new design really provides some efficiency and makes the process more reproducible and able to be done by the operating room nurse. And you can see the machine on the left, and then the cartridge, which is the RECELL Go system. And the cells, or the skin, is placed into the cartridge with the enzyme. It's processed, and then it gets moved around and processed while the surgeon is actually taking care of the patient. The machine can be doing everything. So what I do is start out by measuring the wound first and calculating how much is going to be needed. I can expand 1 to 80 for the autologous cell suspension, and then I'm using somewhere between 50% to 2/3 of the total wound size for the rest of the graft that's going to be widely meshed. I'll take that first so that I can get the skin being processed, and then leave the meshed graft on the back table while I'm actually preparing the wound bed. Sometimes it requires a little bit more debridement, irrigation, and then put the widely meshed graft on. By then, the device has processed the cells, and we're ready to spray the cells on. And you'll see how the machine works in the next video. So this is the machine. That's the cartridge. We're putting the cartridge in and closing the door, and it is working. It's processing in the enzyme, and then it starts to move around, and it tells you how long it is left, and it moves from the enzyme to the buffer. We aseptically take out the cartridge and then suck it up into the syringe, put the cap on, and we're ready to spray. It's a little bit of a learning process because we're used to pressing on a nozzle when there's spray, and in this case, we're pressing on the bottom of the syringe. But once you learn that, it's ready to go. And so it's really a straightforward process. It's designed for very intuitive setup and operation, easy to teach. My PA, if she's available, will do that part of the processing, but our operating room nurses and techs are very familiar with it now too, and they actually find it quite fun. The incubation time is precise, so it's reproducible, and it's a consistent process, and that's what makes this really the next gen in terms of getting a cell suspension. So let's go back to the cases. We're talking about limb salvage, and it's not always the lower extremity. Sometimes it's the upper extremity as well. And this is a patient who had severe coronary artery disease with a recent MI. He's very young. This is his second limb salvage because his other arm required limb salvage as well several years previously. And he needed a fasciotomy to treat a compartment syndrome after failed vascular access in the left upper arm. And you can see that the wound on the far left was really a little bit gnarly, still had some exposed tendon. And so I took him to the operating room and did put the synthetic dermal matrix on and let some of the edema go down before we did the grafting. And then we did the cell suspension with a widely meshed skin graft. Unfortunately, in this patient, I usually like to see my patients every week, and he disappeared for a couple weeks. And so when he came back, he had a lot of hypergranulation tissue. And then when he came back the next time, he's really healing quite well. And he healed in 9 weeks total, but that was really because I didn't see him in the intervening several weeks. So he probably healed earlier than that. No pain, got his mobility back, and he was ready to go to the next phase, which was needing no dressings and doing some rehab for his hand. And then the third case is another one that is truly limb salvage. This patient is a 57-year-old who has very progressive multiple sclerosis. He's wheelchair dependent. He's also a diabetic and a pack-a-day smoker for many years, and presented to me having fallen out of his wheelchair. The story was that he sustained a sunburn. He had a wound on actually both legs, and we're showing the right leg initially looked like a bit like a sunburn, but then became desiccated when he was treated at home and required extensive debridement. He did have tendon exposed in the center, which required that I apply the synthetic matrix. He required some revascularization as well. So I talked about limb salvage using all of our stops, and the vascular surgeon was heavily involved. And finally got the wound bed ready for autografting. And because he did have a lot of the dermal elements on the sides of the wound, even though the tendon was exposed in the center, because of the large size of the wound and that he had 2 leg wounds that I needed to treat, we opted for using the spray only to keep the donor site quite to a minimum, because he also needs to sit in his wheelchair, and this is on the back of his leg, so I needed to position him prone. So accessing donor site was a challenge in him, and trying to keep it to a minimum and yet still get him to heal. And so you can see that it was starting to look good. And in the next series, you can see how he healed. He did have one small area of bone that was exposed in the center, and that just little pinpoint area took a little bit longer to heal, but the rest of it healed and has been durable, and he was able to be discharged in about 16 weeks. So really did well with a large wound in a very, very sick patient. RECELL has established reimbursement, so we know how to code for the wounds, and if coded properly for the wound, we'll also get reimbursed for the graft. It's a combination of a split thickness skin graft and an epidermal autograft, which some of us weren't familiar with that coding, but it's the 15 110 series as opposed to the 15100 series, covered by Medicare. In the outpatient setting, may vary with other payers, but the reimbursement is good. And the payment for the physician, I assume, is good. I'm salaried, but we know that on the back end, the assistants and the staff from Avita help with hospital reimbursement, and it also covers the device. And I haven't had any complaints from my hospital, so I assume we're doing okay on that. The clinical advantage also translate not just for reimbursement, but also for cost savings. So compared to conventional autografting in the burn literature, it's been shown that there's been a good reduction in length of stay with tens of thousands of dollars of cost savings per patient, depending on the size of the burn. And in non-thermal full thickness wounds, we expect that the same will be true. I do most of my grafting as outpatients unless they were still in the hospital for another reason. But most of the time, the patients have gone on to an outpatient scenario, and I bring them back only for the grafting, and they remain outpatient. I don't admit them after grafting unless there's some other reason to. But it still does lead to reduced length of stay because I can have a plan and process and know that they can be discharged and I can treat those wounds later. I have the advantage of also being associated with the wound center. So my patients come through the wound center and we have great nurses that take care of it. And that really helps with the whole cycle of care, going from hospital to home, possibly with home health, sometimes to a facility, and then through our wound center so we can get our patients healed expeditiously. So in summary, I think it's important for plastic surgeons to be aware of this because it's yet another tool that we can use. Really reduces the donor skin amount, and it's very thin, causes less oozing, especially in the anticoagulated patients, and I can use it to heal a variety of wounds. We have good outcomes that will translate to reduced patient burden, hospital burden, and reducing the overall cost. And then, as I mentioned, Avita Medical offers training and the support that we need in terms of educating the staff, educating my nurses. So when a patient comes back to clinic, we know that if I'm, for some reason, I'm not available, the Avita staff can be there to help the nurses know what's underneath the dressing. And likewise, if a patient goes to a facility or home health, there's support for that as well. So I think that that's really important. RECELL process was developed to solve a real clinical problem. It's a true bedside to bench and back process, which is something that's just phenomenal, and it's point of care. So harvesting the graft, the enzymatic processing to create a cell suspension, and applying to the wound bed, it's all done in the operating room in about 30 minutes. So I think that it provides a distinct advantage over some of the other things that we can do and can help get our patients healed. It's always important to be aware of the indications for use, and now it's in addition to application to burns, the RECELL is available for full thickness and partial thickness non-thermal injuries. And I thank you for your attention and hope that there will be some questions.
Excellent job. Thank you so much, Dr. Gould. We love the presentation. It was really amazing to see your case studies and be able to see how you're currently using RECELL in your clinical practice for best outcome. A couple of the questions that are coming in, I'd love to share with you and give you a chance to respond. First one is, compared to your pre-RECELL use, has there been any noticeable difference in outcomes that you see today, specifically cosmetic, with pigmentation, or healing time?
Yeah, I think that's really important. I think what I've seen, well, one is the donor site cosmetically is very nice and it heals very fast. And that takes away some of the worry from the patients because they're just scared to death about the donor site. They've heard about that over and over. The grafting itself, because the cells are sprayed over a very widely meshed graft. I mean, you would think that you're going to see this horrible meshed pattern, and that's what we all think about when we think about, say, somebody with a really bad burn that required, say, a 6-to-1 mesh. But with the spray over that, it fills in those interstices, and I think in some of the cases I've seen the interstices heal better than where the graft actually, the wide mesh graft is. So it really fills it in and makes it smooth. And it's very durable as well. And then the pigmentation, I think, is a big advantage. I haven't seen what happens when patients go out in the sun yet, but I always advise them to use sunscreen on those injured areas anyway. But they have melanin in there, and so it should be pretty tolerant to sun.
Great. Thank you for sharing that. The next question that's come in is, do you have any experience using this with negative pressure wound therapy over the RECELL treated areas? And if so, what is your dressing protocol when using pressure device?
Yeah, I did. I didn't show that, but one of the advantages that I've found with RECELL is that I can do the grafts on a more heavily draining wound than I normally would, because the actual number one cause of graft failure is either seroma or hematoma. So if you get fluid under the graft, they won't heal. But with RECELL, I can use the negative pressure over the graft. So I will dress with the Telfa Clear, which we really didn't go into, but it's a special dressing that's very thin and permeable and is clear. And then do usually an adaptic, which is, again, it's a non-adherent gauze, but a bit more permeable than Xeroform is. So put that and then the negative pressure over that, and leave that on for at least 4 days, as long as it's holding a seal. If I'm comfortable enough that the seal is being maintained, I'll leave it on for a week, but usually take it off at 4 days, very cautiously, leaving all the underdressings intact, and then putting it back on for another week.
Great. We have another question. What is the skin sensitivity like after the skin graft takes with RECELL?
So far, we don't have the really long-term outcomes. I have one patient now who was my first patient. I started doing this in August of 2023, and her graft site is very durable, very pliable, tolerates. She has to wear stockings because of leg edema, and tolerates pulling the stockings on over that, and hasn't had any problems with skin sensitivity.
Great. We have one more question today, and I'd like to, this person specifically asking about, have you seen a large decrease in length of stay with these types of patients treated with RECELL?
I think that's possible. As I mentioned, most of my patients, by the time they're ready for a graft, are either discharged or the hospital is anxious to get them out of the hospital. So in my practice, it doesn't really change the length of stay because I'm doing most of my grafting on outpatients. But I don't keep them in the hospital for a graft. That it's an outpatient procedure, come in and go home the same day. I have really a strict protocol. I think consistency is one of the most important things, keeping a protocol for how the graft is dressed, how the donor site is dressed, and good instructions to the patient and to anyone that's going to be their caretaker. And then quick follow-up, say between 4 days and 7 days in the clinic is when I usually see my patients back.
Great. Outstanding presentation today. We're very grateful from Avita Medical for your time and attention in producing this webinar with us and sharing your case studies, which ultimately show really high quality patient outcomes. So thank you so much for joining us today, and we look forward to your additional questions offline. Thank you.